This lecture is about osteomyelitis, and there's a couple of things I'll point out to you that are just crucial for you to be able to put this in your differential diagnoses when you see someone. So osteomyelitis is an infection of the bone or an inflammation of the bone caused by infection. It's one of the most difficult to treat infectious diseases, and actually you'll hear me later to say we're trained to use the word arrested versus cured because it's very difficult to cure. We're going to focus more so on acute osteomyelitis for a few minutes. It's an infection before the development of bone necrosis, and that's in comparison or contrast to chronic osteomyelitis, which already involves necrosis of the bone. So there's three groups, okay, related to epidemiology that I want you to remember. There's bacterial cause, so three groups of causes. Contiguous focus, or like a puncture wound or a foreign body, or surrounding soft tissue infection, which infects the bone. And the third is associated with peripheral vascular disease. It can be, again, divided into acute or chronic, and our focus is mainly on the acute. Less than 5 years old, we see 50% being that bacterial seeding and one bacterium. And then the next most common group is in the older adults. The pathogenesis of osteomyelitis is affected by the organism and its virulence, the age of the patient, their immune health, if they're immunocompromised, and any comorbidities that are present, and type of bone infected. So all those play into this disease. Staphylococcus aureus is the most common pathogen, 70% in children, and it's also the most common pathogen in adults. Unfortunately, we know that methicillin-resistant Staphylococcus aureus is on the rise, and we always have to keep that in mind as how important it is for those cultures to be obtained. So clinically, the presentation is largely a clinical diagnosis with supporting data. So you have to be a good history taker, like we always say and know. Children might present with a fever, decreased range of motion, and pain that developed over a few days to a few weeks. In adult, it is less common to see the hematogenous type, but when it does come, it's usually in the vertebrae. So there is some other primary source of infection, and it seeds into the vertebrae. I think our book gives us the example of pericarditis, so it's so important not to miss that. And it might be your first assessment of that patient. Adults, we can see fever, pain, erythema, and swelling. However, commonly it's a really subacute presentation. Physical exam, I want you to review on 981 and 982, okay? The physical exam may elicit some bone tenderness. However, what our Butera has done for us is said, hey, it might have bone tenderness, but let's divide these physical exam presentations that we need to be very aware of, and thinking in our clinical reasoning that this could be a presentation of osteomyelitis. So I want you to look at the vertebral osteomyelitis, okay? Back pain's the most common initial symptom with vertebral osteomyelitis, okay? Go back, and even though the diabetic foot ulcer is the classic example of a contiguous focus of osteomyelitis, you know, that has to do with venous insufficiency. And it could be an acute presentation versus a chronic presentation. The third area I want you to look at is Pseudomonas infection of the foot. It's a unique form of infection that follows a puncture wound, such as a nail through the shoe. We don't want to miss that. And there's classic signs and symptoms. But I'm more interested in you recognizing these are scenarios that would heighten my suspicion. And then sickle cell disease. So patients with sickle cell disease are at a high risk for osteomyelitis, especially in areas where decreased blood flow has led to infarcted bone. So put that in your caveat. Differential diagnoses, the top three, often have to differentiate between septic arthritis and osteomyelitis, but both are emergent. Gout can present very much misleading to osteomyelitis, but I don't think anybody's going to fault us for ending up with a diagnosis of gout when we suspected osteomyelitis. And then the third is a post-traumatic periosteal reaction. Sometimes in that x-ray will look very much like osteomyelitis. Management, we are going to make consultation and referral to infectious disease specialists, surgeons, wound care specialists early in the treatment, and any suspected epidural abscess needs to have a neurosurgical consult. Just review those on page 983 and 84. And then referral. The very first thing we think is immediate emergency department referral so that we can get everything started and they have the tools for proper assessment. So, but these things should alert you instantly. Any neurologic symptoms, septic symptoms, severe cellulitis or abscess, or severe diabetic foot infection. And then patient family education. Of course, various diagnostic and therapeutic options. That's the second point, is that cure is elusive, so most appropriate to state that it is arrested. Interesting that acute osteomyelitis can relapse years after treatment. I do like this photograph. It examples osteomyelitis in this x-ray. So when you're thinking about osteomyelitis and how serious it is and the tremendous amount of time it takes, antibiotic therapy is usually minimally 6 weeks. I really want you to hone in on those unique characteristics of this infection because it's critical that we don't miss it. Thank you.